All right. Well, thank you, Tara, and thank you all for being part of this today. I'm just double checking to make sure that I don't have myself muted or anything dumb like that. Okay, I think we're good. So I want to go back a little bit. I've been having these conversations with a number of my colleagues that serve on the health committee with me for several years about how can we have the biggest impact. And there are a lot of ideas. We do some flashy things like the public option, but I see a lot of these things as being very limited or impacting kind of a narrow percentage of the market. And I don't have a ton of time to read journal articles, but I did invest in this particular area. So a couple years ago, I started reading everything I could find in Millbank or Health Affairs about APMs, particularly in primary care. And then, I wasn't the sponsor on the 2019 bill, but I did help with it a little bit and have been pretty interested in following those annual reports. And so as I think about what are the biggest things we can do to make our healthcare system work better, two things have consistently come to mind, and none of these are new, right? These are things people have been talking about for a long time. One, invest in preventive care rather than sending people to the emergency room. And two, paying for healthcare differently, paying for value instead of volume. So I had kind of been seeking out where can the legislature pass a bill that adds value to the work that's already being done. And this idea around multi-payer alignment that was contained in one of the collaborative's recommendations really jumped out at me as something that I thought could have a powerful impact. And so, there were a lot of things already happening. The DOI had promulgated rules establishing these targets. And then, what I was noticing too is a lot of health insurance carriers were starting to take up APMs, but in a lot of ways they were doing it their own way. And I think that, there's an understandable tension between, innovation and letting these companies kind of get out there and figure out new ways to do things versus alignment, which streamlines things on the provider end. And I think that, understandably, the health insurance carriers had a greater focus on that innovation with a little bit less interest in the alignment piece. And so that was part of what we were hoping to accomplish with this bill this year, is kind of take that step forward on pushing greater alignment between all these things that are part of payment models, because by doing that, you can increase the uptake of APMs among the providers. I think the second thing that we were running into is there's healthy skepticism of APMs out there because a lot of times it's brought up in the context of saving money. Now, saving money on healthcare is a huge part of what a lot of us have been talking about at the state capitol for several years, but there's a really important distinction to be made. We shouldn't be saving money by reducing our spending on primary care. Primary care, if anything, we should be spending more money on to bring down costs elsewhere in the system. And so we wanted to make sure that, there were questions about how the DOI might implement things through rulemaking. Now, I have a lot of confidence in how that would go based on the people I know who are over at the division and do this work every day. But, not everyone knows them as well as I do. And there were questions about what was going to happen. And so making sure we established in statute that this was not about crunching the primary care dollars into a smaller pot. It was really about increasing the value of our outcomes. And then connected to that same goal was this emphasis on equity. I think, this came up in a budget conversation earlier this year, but in maternity care, there has been concern that by switching to APMs, there's a risk of reducing access or putting further downward pressure on a system where providers may already be under reimbursed or where there may be very, very inequitable outcomes. And so we thought, and when I say we, most of the time I'm referring to myself and Yadira Carveo, who is my co-prime sponsor on this, that by codifying some language around the importance of equity and reducing health disparities, that we were going to be guaranteeing for the future that the progress we make on APMs would not come at the cost of the patients who have historically faced discrimination or really struggled in this system. And so that's where all of this started. Let's go forward one slide, please. So early on, it was based on these recommendations of the primary care collaborative that we started taking some inspiration. So I called Tara and we started brainstorming about how a bill could add value to the work that was already being done by the collaborative. At the same time, there were a couple other things that were happening, one of which was that the Division of Insurance had put in a budget request through the JBC, through the regular budget process, to provide funding for in additional collaborative work. You know, the collaborative was doing its work, the state transformation collaboratives are kind of starting to get off the ground, and then we had this BAILIT project that was mentioned in other slides before. But we also wanted to you know, figure out a way to bring everyone together to the table to make sure this doesn't just end up being another report that ends up sitting on people's desks. We wanted this to get translated into action. So the Division of Insurance put in this budget request, which was approved ultimately, but we weren't sure whether that would be the case when we first introduced the bill, that funded more collaborative work, bringing in these stakeholders, bringing in the payers and providers and everyone else you can imagine in this space to dig in and start turning what had been a lot of studies into what would ultimately become really meaningful action. So that budget request established the process more than anything, and then we put in this bill some language that, you know, made very clear that we are intending for this to not just be within the commercial insurance market. We are hoping that this, you know, brings in Medicaid, potentially brings in Medicare, depending on how some of the collaborative work goes, and learn from the best practices of all of the above. You know, we certainly don't want to find the lowest common denominator here. Since everyone else has used the word denominator in their presentations, I had to drop it in here somewhere. But we don't want it to be the lowest common denominator. We wanted everyone to learn from the best practices and raise the bar. And so by establishing this process where everyone was involved and making clear that the goals are increasing primary care investment, improving health system outcomes, increasing access, reducing health disparities, and, you know, certain other elements that we know contribute to better care, like integration of behavioral health care, that we were going to really drive this in the right direction. Next slide, please. So in many ways, what the bill did was not exactly earth-shattering. It you know, in some ways it was a clarification or a reinforcement of existing language, or just making very clear that these are what the goals we wanted to be in place. Because in some ways there were arguments the Division of Insurance already had rulemaking authority to establish some of these things. But for us to make it very clear in this bill, and for us to make the goals very clear, I think we're able to guarantee that the programs will be designed in a way that achieve the outcomes we're all hoping for. So really the crux of the bill was giving the Division of Insurance explicit authority to establish parameters that need to be aligned across APMs. And these included a certain set of quality metrics, so that we're not saying, you know, insurance company A is making provider A use these quality measures, but insurance company B is making provider A use this different set of quality measures. It makes no sense for a doctor to have to log into their insurance portal to find out which quality measures are going to determine their payments. And so that establishment of aligned quality metrics was maybe the most important part of what we were trying to establish in the bill. And these other elements about risk adjustment methods, you know, if risk adjustment is done wrong, that is the kind of thing that can incentivize doctors to drop their most expensive patients. We want to make sure we're actually incentivizing them to take on the more expensive patients that have maybe been historically underserved. The attribution methodologies, this is more of an administrative thing than anything, but if we make sure that all the insurance companies are attributing patients to practices in the same way, it's going to dramatically improve simplicity for providers in this space, and also the core competencies of what your practice is expected to do to be able to participate in an APM will help with that simplicity. And so the DOI will be promulgating these rules after they complete all of this stakeholder process that has been funded through the budget request. And then starting January 1, 2025, the insurance carriers are going to have to make sure their APMs are aligned. And it is our hope that by doing these steps that we're going to make it that much easier for providers, provide assurances that this is a smart move, that this is going to improve outcomes for their patients, and make sure that they continue to be paid and hopefully get paid more for the work that they do. And we're excited to see where this goes in the years ahead. So I'm grateful to all the folks on the call. You know, Tara and David and others were collaborators from very early on in the process, and I'm grateful for your help in turning this bill into a law. And with that, I'll turn it over to Trevor Abeda at Healthcare Policy and Financing.